Beginning, there was another person. Is this a camera?
There's somewhere in there. Probably in the middle.
Is that a video?
Yeah.
Oh,
The
the
camera's probably in here.
I know that, but I mean, my picture's
Hi,
not.
there's
It won't be on there. It could be on theirs, maybe.
there.
I thought it would be in a corner.
I don't think it's on your phone.
Okay, folks,
Oh,
this is
yeah.
Mary Sue with Michigan Parkinson
Okay.
Foundation. And I want to welcome you all this evening. We're really fortunate that we've got Dr. Laurie Boore, who is a geriatric psychiatrist at Henry Ford Health System. And she is going to talk about mental health issues and Parkinson's. So I am going to mute all of you now, and we will be getting started, okay?
Okay.
Or as soon as I mute everyone, you'll have to unmute yourself, okay?
Could do what?
I can't hear that.
The silence was deafening. Should I unmute myself, okay? I was hoping to just cut out all the chatter. Well, good evening, everybody. I'm Dr. Laurie Boore-Clore. I just go by Dr. Boore because that's what I've been forever. Today we're going to talk about the mental health needs in Parkinson's patients. And if you have any questions, please somehow get my attention or put it in the chat, and I'll try to address it as we go along. We'll have time at the end too for questions, but sometimes you really want to jump on something as I'm talking, and that's totally fine. So I'm a psychiatrist, I'm a physician, I'm not a psychologist, and I'm not a therapist. So a lot of times psychiatrists and psychologists get confused. So I just want to make that clear that I'm a medical doctor. I went to Wayne State for 4 years, and then I stayed there for 4 more years to do a psychiatry residency. And then I got tired of it, and I said I wanted a change of scenery. So I went to the University of Michigan for a fellowship year, specifically in geriatric psychiatry, and that's where I got a lot of exposure to Parkinson's patients. From there, I stayed on at the VA hospital in Ann Arbor for another 7 years until I got a phone call that I wasn't expecting. I had actually been working on the computer, and I grabbed my phone when it was ringing. And if it's a physician recruiter, I don't answer. If it's coming out of Texas from a very specific phone number, I don't answer. But I was busy and I didn't look at the phone, so I just picked it up and said, hello. They introduced themselves as a recruiter, and I just said, oh no, why did I pick up the phone? But it turned out it was Henry Ford Hospital. They wanted a geriatric psychiatrist specifically for their neurology department. So I would spend most of my time in psychiatry where I belong, but then I would spend 2 days a week in the neurology department specifically for patients with Alzheimer's and other dementias, and for the movement disorders clinic for Parkinson's, Huntington's, Lou Gehrig's, things like that. I tend to focus more on the Parkinson's patients because I like you guys better, but don't tell them that. I really do enjoy working with my Parkinson's patients, and if any of you are here on the video, please do not call us out and ruin your patient privacy, okay? So I've been at Henry Ford now for over 1.5 years. I'm also a mother of 2. One of them is about 3.5, and she may bust down the door. A couple of my patients have met her because she likes to wave to people on the video, but my husband has got them both tonight, so we may or may not see my apprentice. So tonight, what I want to do is I want to discuss the major psychiatric symptoms of Parkinson's and how to manage them. Most people consider Parkinson's to be a motor disorder only. So it affects how you walk, it affects how you stand up, it affects your face, swallowing muscles. There's a lot more going on because it is in the brain, and the brain is very highly specialized. It's also very tricky to work with sometimes. And for no reason at all, we'll get Parkinson's psychiatric symptoms. But they're manageable. There's non-medication options and there's medication options. And then at the end, I have some resources and some ideas that I put together too. So to start, whenever you come to see me or another doctor, we will do a full medical exam. Except right now I'm virtual. So I am trusting my neurology colleagues and my primary care doctors to have looked at you from head to toe, to hit you with the hammers and make your reflexes bounce, make you walk up and down the hallway. We always want to see, are we missing something else? We don't want to miss anything and mistreat a diagnosis We don't want to cause any suffering. So we want to make sure that we've got the right thing that we're targeting. Sometimes Parkinson's and the symptoms within Parkinson's can be due to an infection like a bladder infection or pneumonia. So when they come on, we want to make sure that that's not what's going on, because it's easily treatable with an antibiotic. But if we're not thinking of that, if that's not on our radar, we're chasing our tail and not getting anywhere, and the patients are suffering. So here often that, especially in patients that live in nursing homes, that they colonize their bacteria in their bladders. This isn't true. To me, it's just a cop-out for somebody else to do the work to find out what's going on. As you get older, you don't have the fever response like you do when you're a child. Children get fevers all the time, but when you're an adult, you get less fevers because your thermostat and your brain is changing, just like every other part of your body as you age, and you don't get that fever. The other thing is you don't get the white blood cells, the fighter cells. They don't mobilize like they used to. And then you can have a full-on, what they call fulminant pneumonia, and there's no fever and there's no white blood cells to tell us that. That's why we want to listen to your lungs. That's why we want to do all of the physical exam findings first. We'll get lab results, we'll look at chest x-rays. We just want to know that you don't always get a fever. You don't always get a white blood cell count. Another thing we'll do when you come to see us is we'll look at every single medication you take, every single supplement, every single vitamin. We want to make sure that they're not playing a part of the picture. We want to make sure that they're not interacting with each other and causing more trouble. And just for later, more importantly, later down the road in the talk, just because the side effect is listed in the thing that comes from the pharmacy doesn't mean it has to happen. It can, it doesn't mean it has to. So it's the same thing with looking at your medications, because they'll say, oh, this can cause depression, this can cause anxiety. It doesn't have to, but if it is a risk, we want to know. So the other thing that we'll do is we'll look at, like I said, drug interactions and drug effects. We want everything. Are you taking Tylenol? Are you taking Motrin? Are you taking Miralax? Are you taking a stool softener? All of this can act and do something different that we don't want it to. What we like to do is we really like it when you bring a family member with you, whether it's your spouse, your children, your neighbor, anybody in addition to you, because they might be seeing something that either you're not or you've gotten so used to that you've just learned to accommodate it. Also, I find that spouses really like to talk about their spouse to me and what's wrong and please fix them. I don't use that word fix them. I like to help, but spouses come and say, please fix him. So, but that's what I like. I like to have the information that they are seeing. The other thing I'll do is I'll evaluate the environment. I'll ask you all kinds of nosy questions about your house, about where you live, who you live with. Sometimes things in the environment can make our brains play tricks on us. And I want to make sure that that's not happening, because there are some situations you might end up with a medication you don't need, and that's not going to help. If some people are in an assisted living facility, or if they're in a nursing home, I love to talk to the staff. The nurses are there around the clock. They know my patients better than the doctors that come in and out. The doctors will come in and talk to you for about 5 or 10 minutes, but the nurses are there for their whole 12-hour shift. So they see stuff from start of shift to end of shift, and that's very helpful. It includes meals, it includes family visits, it includes all kinds of regular activities that are going on in the daytime. And I'm nosy. I want to know what is going on so I can help. One of the biggest things we'll do in the acute setting, so in a hospital or an emergency room, is we want to rule out what is called delirium. Delirium is a medical emergency, and it can make any and every psychiatric symptom show up. So people who have never ever in their life heard voices start hearing voices, where they start seeing people in the living room that have never been in there before. Depression, anxiety, all kinds of things. And we want to make sure that that's not what's happening, because to fix or help, the problem is we have to treat the underlying cause. Some of those underlying causes I've mentioned, like bladder infections or pneumonia, but it can be pain. It can be alcohol withdrawal. And believe it or not, it can be cocaine intoxication too. I have a bunch of elders that still use cocaine or marijuana. But again, we want to make sure that's not happening. One of the biggest causes for delirium in the patient population over 60 years is their medications. So that's why I say we look at everything. But delirium is when the loved one says they were fine yesterday and they're not fine today. Something is wrong. When it's that fast, that's a delirium. And that's when we need to have everybody on board to look and figure out what is going on so we can do it and undo what's going on. Then this is very important because, again, if the depression is being caused by a delirium, no antidepressant in the world is going to help the situation. If somebody is hearing voices or seeing things, our antipsychotic medications are not going to help at all. So if it's the bladder infection, they get the appropriate antibiotic, the infection clears. It can still take weeks to months to fully resolve, but that's the issue. That's what we needed to tackle. That's what is going to clear this up, not anything else. It's kind of like trimming the bushes, the branches on the bush without chopping it down. If you want the bush out of the way, you have to chop it down. You can't just keep trimming the branches because it's just going to get smaller, but it'll grow back in certain spots and it just doesn't get anywhere. One of the biggest psychiatric symptoms in Parkinson's is memory loss. People who have had Parkinson's for a number of years can start to show short-term memory problems. And you'll see it when they repeat themselves. They'll repeat their questions. What's for dinner? We're having meatloaf. Oh, okay. 5 minutes later, what's for dinner? What's for dinner? Where are we going today? Where are we going today? And the spouse or the loved one gets so frustrated because they've just answered this question 5 times. They'll forget names. It's usually the younger generation of grandchildren and great-grandchildren that are the hardest to remember. The spouse is usually the last name that they will forget. Interestingly, in the most advanced cases of dementia, they don't forget their name. They can't tell me what their name is, but they will respond to it. So one day I saw a gentleman in the nursing home and his name was Bob. And I walked in and I said, "Hey, Tom, how are you doing?" And he didn't even flinch. I said, "Hey, Michael, what's up?" He didn't move, he didn't flinch. I said, "Hi, Bob, I'm here to see you today." And he looked and he had that glimmer in his eye of something's familiar here. But he didn't answer to the other names, he answered to his own. Forgetting medications and from medical issues is a big thing for us doctors. We like you to take your medications on a very regular basis because they will help you. We'll watch your sugars, we'll watch your hemoglobin A1C go up and down, and we can tell that's a medication compliance, that's a diet compliance. So where is the medication forgetfulness coming from? Is it putting the pills in the pill box and then forgetting to take them? Is it forgetting to get the refills from the drugstore? Where is the forgetfulness coming? We want to look at all the stages there. Forgetting medical issues, I'll ask my patients what kind of conditions they have. I'm looking for high blood pressure, diabetes, Parkinson's, ALS, anything. And they'll say, "Oh no, I'm pretty healthy." And I look at their medication list and I say, "Well, it looks like you're taking a medication for your blood pressure. Do you have high blood pressure?" "Oh, I must," is the response I get back. But they won't tell me, but they might remember. Getting lost while driving is one of the scariest things I've ever had to deal with. I have had so many patients rescued by OnStar. I think I need to send OnStar a bouquet of flowers because I have people that make it all the way up to the Mackinac Bridge and they have no idea how they got there and they have no idea how they're getting home. I had a patient once leave my appointment and I said, "Sit in the waiting room, your wife is going to come and get you." And we watched him go to the bathroom and he didn't come back from the bathroom. He went and took a trip and his wife came to get him and we couldn't find him. So she called OnStar and OnStar was able to track him down and get him back home. Managing finances. In some couples, one spouse always managed the finances. So if they've never managed the finances, my question is moot. But if somebody is an accountant or they've been managing finances for the family, for a business, something that they've been doing finances for a long time and now that role has shifted to somebody else, I want to know why. Have there been multiple withdrawals? Are they giving their money away? Are their checks bouncing? What is happening financially? I had a gentleman that bought 4 houses and a Cadillac. His language was very well preserved and he could have a very good conversation with you, but he didn't understand why he was buying 4 houses. He could sign the papers just fine, but he didn't understand the terms of the mortgage. we managed to get that all straightened out with a couple letters to the judge and to the mortgage companies. One thing we like to do when people are exhibiting memory loss is we like to keep routine and structure a part of their life. They may not consciously remember what the next step is going to be, but their body does. Their body somehow knows that they're going to wake up, they're going to take a shower, they're going to get dressed. Next is breakfast. After breakfast, we do these things, and then it's lunchtime. So we like to keep it routine and structured because when you take them out of the house to go to the doctor, it throws it all off because they're not used to going for the car ride. They're not used to going out of the house. Sorry? I heard somebody, so that was. Regular exercise. I love it when people tell me they go for walks every day. Exercise is the cure-all. Exercise will keep you healthy, it keeps your blood pressure down, keeps your sugar regular as best you can. Sometimes the loved ones and the spouses take it personally that their loved one can't remember their name, and there's nothing personal at all about it. Nobody chooses this path. So we always ask people to stay calm. Although being called by a different name or not being recognized is painful, try not to make it apparent because then the loved one with the memory loss doesn't understand why are you hurt, why are you upset. Respond with a brief explanation. What's for dinner? Meatloaf. We're having meatloaf today because tomorrow we're going to have chicken. We had spaghetti on Monday. They don't need the week's menu. They just need to stay on today's dinner menu. Or the most painful thing is when people don't remember that their spouse died. So they'll say, where is my husband? And I will touch on that question later. Where is my spouse? Well, he passed away 5 years ago. And every time you tell them that they passed away, it's like the day it happened all over again. It's a ton of bricks hitting them. It's the worst thing that could have ever happened to them. And making them relive it over and over is very painful for the patient and everybody else in the family. So sometimes we have said they've gone on a business trip. Oh, okay, when will they be back? Tomorrow. Tomorrow comes. Oh, where's so-and-so? Oh, he's on his business trip. He'll be back tomorrow. Oh, okay. Some patients can still remember that their loved one passed away when you tell them. So we'll have them make shrines. They'll put their wedding picture in a special corner. They'll get the obituary and put that there too. A necktie, a wristwatch, something so it makes it special for them. Oftentimes when people have memory loss, they get stuck in a time period and we can't advance past that. And that's why it's mentioned about the grandchildren and the great-grandchildren. If you ask the person who the president is, that's usually where they've gotten stuck. If they say Bush, you've really got to clarify. Is it Bush Sr., Bush Jr.? I've had all kinds, the dumb one, the smart one, the old one, the young one. I have no idea. So when it comes to Bush, I have to really work on clarifying which President Bush they mean. But that tells us what do we need to do? How do we need to act? Who was born after that time? Anybody born after that time might not have made it into their memory bank. Sadly, I have a neighbor that has Alzheimer's and he's the sweetest guy. I somehow made it into his memory bank when I moved in here by myself 7 years ago. I got married 2 years after that, and he would come up to me on the street and he would say, Laurie, who was that man in your house? It's like that's my husband. Oh, okay. I didn't know you got married. Oh yeah, I got married 2 years ago. And he was, oh, okay, as long as you're okay with that man in your house. And then 2 years later, we had a little girl and he remembers her, but he doesn't remember my husband. So sometimes their memory is spotty like that and we don't know why, but he just adores my daughter. He will ask about her and he will get her on the street and he'll say, and how old are you? 2 seconds later, and how old are you now? And she's really great with him. She just answers that question and she says, Mr. Bill, will you play with me? And off they go and they play. And he says, what is her name again? And then he'll say, Laurie, there's that man in your house. And it's so heartbreaking to watch it because you wonder, where did he stop in time? Was it 5 years ago, 4 years ago? It's mostly 7 years ago. I have a family that they know their loved one stopped in about 20 years ago. So I said, okay, well, 20 years ago, what if you got her a different kind of telephone, not an iPhone, the one with the big numbers. Remember the ones with the really big numbers that you had to push that was set up like a grid? So they did that. That worked for a while, and then her memory changed. So they got her a rotary phone. Lord knows where they found a rotary phone. but they got the rotary phone and she was able to call her loved ones again. Offer corrections as suggestions. So if you don't want to say mean stuff, that's not a fork, that's not a spoon, that's not this, and that nasty tone of why don't you know this? Because they just don't. So we'll say, oh, I thought that was a fork. Oh yeah, I guess you're right. I guess it is a fork, somebody will say. Or they'll ask me, who is that person? I think that's your granddaughter, Julie. Oh, that must be Julie. Okay. Well, I don't want to say, how do you not know her? That's your daughter. That's your granddaughter. She lives with you. To say that or to be like that is very distressing. It doesn't help my patients. It doesn't help me. It doesn't help my loved ones. So I have a story about a patient I had a long time ago. He had a son named Tom and a brother named Tom. And that name has obviously been changed to protect their privacy. But Tom, the brother, had passed away a while back. And Tom, the son, looked nearly identical to Tom, the brother. So I could totally see why my patient did this. But he started calling Tom, the son, his brother. So the patient and his son would come to his visits, and the son would get all upset. I'm not your brother, I'm your son. Why can't you remember this, Dad? And I had had multiple conversations with him. Please don't take it personally. Just play along, it'll make it much easier. It's not that he doesn't love you. It's not that he doesn't remember you yourself. It's just his memory is changing. So finally, Tom, the son, started to play along, and everybody got less stressed out. It was so much better. So he would say, Dr. Boore, this is my brother, Tom. And so nice to meet you, Tom, every single visit. Even though I've talked to the son on the phone, I've seen him multiple times, but we just play along because it takes the stress off of everybody. The question has come up about what is the difference between Alzheimer's dementia and Parkinson's dementia. Alzheimer's dementia is a gradual decline. It starts usually like the first line of the slide with, repeating self for short-term memory. What did we have for breakfast? What did we do last week? Whose birthday is coming up? And things are gradual. The marking point I use is 7th grade. The tasks that you learn after 7th grade include algebra, which is abstract thinking. Anything that requires abstract thinking is the first to change in Alzheimer's. That's why I ask about finances and driving. Those are driving is very concrete. I mean, you put your hands on the steering wheel and your feet on the pedals. But the thought process is very abstract because you are processing multiple input at the same time and making decisions off of that. Finances, higher, like managing your retirement, higher order things like that. And even sometimes paying the bill, like at the grocery store with cash, that can be considered abstract. It's abstract enough that we see it change first. So it's things like that, things that require you to take care of yourself or your loved one to take care of themselves, that starts changing. So then we look at 7th grade, and you see under 7th grade, children can make themselves a sandwich. They can get their clothes on. They can brush their own teeth. Then you see that starting to change. They need help with their clothes. They need help with their dinner. But then you watch them eat. They no longer know how to use a knife and a fork. You think about how children develop. They start with finger food. After you feed them a bottle, after you feed them yourselves with the spoons, they start using finger food. From finger food, they go on to the children's utensils. From the children's utensils, they go to the adult utensils. So then you see that starting to change backwards. So then they start using children's utensils, and then they start using finger food. And for families, it's very distressing when we used to be able to go to the restaurants and people would be eating their spaghetti with their fingers. But that shows us where the regression is. Parkinson's dementia is a little bit different. It happens in the same, more or less the same fashion, more or less that same trajectory, but it happens a little bit faster. Alzheimer's can go on for about 5 to 7 years before you get the diagnosis of Alzheimer's. With Parkinson's, it's more like 3 to 5, 2 to 3 sometimes. And you'll see it in big ways. So you'll see the behavioral issues come on with it sometimes. And we'll talk about those in a little bit. But you'll see bigger chunks happening. So most of the financial stuff, the medication, the driving, that happens in a chunk. In Alzheimer's, it's a little bit gradual. Well, today it's finances, and over time we realize finances are not being tended to. And then now we realize that medications are not being tended to. Parkinson's patients can live for a very long time before they get dementia. A lot of them don't even have to get it. Nobody has to get it. So people are fearful of Parkinson's dementia because it's part of the package, because your brain is changing. It doesn't have to happen. So let me tell you that first. The medications that we use to treat Alzheimer's, we use for Parkinson's as well. And I'll talk about those in a little bit. In advanced Parkinson's with dementia, we'll see a behavior called sundowning. This happens in Alzheimer's and all kinds of other dementias as well. And for some reason, it happens 4 to 6 p.m. every night consistently. We call it the witching hour. We know that it's going to be brutal. It's going to be uncomfortable. Patients are going to pace. They're going to pick at their clothes. They're going to whimper. Any behavior seems to escalate between 4 and 6, and magically at 6 o'clock, 6:30, it just goes poof for absolutely no reason. There are no good theories as to why this happens. We have heard that it's the gravitational pull of the moon. We have heard that this is interesting, in stay-at-home moms or stay-at-home dads, when the children got home from school, through dinner time, 4 to 6 p.m. is the busiest part of their day. It's the most hectic, it's the most transitional. So people wonder, did that have something to do with it? Because there's none of that now. It's calm, but they're programmed to do stuff between 4 and 6 p.m. We don't know. Again, it's another theory. When I say property destruction, that's for pretty severe cases. Usually it's a wandering around the house looking for something to do, escalating questions, but sometimes I have had people decide that they're going to cook and burn down the kitchen. I have had people run away from home. I have had chairs thrown. It's very sad. It can be very destructive, which is why I always ask about it, and which is why we need to know. So please, if this is happening at home, please tell the doctors. What we like to do during that time is we like to avoid medication because it's still too early to go to bed, but it could lead to damage at home and it's very uncomfortable. So we try to help minimize the damage. We want to keep people busy, offer them snacks, try to get them dinner, keep on that schedule. Don't ever make an appointment anywhere between 4 and 6 p.m. for somebody who has dementia. It does not go well. They need to be home. We ask people to avoid stimulants like coffee because that can really rev people up. We like to have people have more activity in their days before 4 p.m. because sometimes that tires people out enough that they will sit still, that they will fold laundry, that they will watch TV, they will do something instead of pace and whimper or wander. I have a family that will go for a car ride from 4 to 6, and they take the same route, and it's about an hour drive. So they get out of the house, especially now with COVID-19 and all of the restrictions. It's very good for both of them. Folding laundry is simple enough. Sometimes it's not simple anymore, but if any little task like that to keep somebody busy, keep their mind off of things is good. Some people storm out of the house, and this is a very touchy subject. Some people don't want to put different locks on the door. Some people fight. They'll stand between the patient and the door, and the patient tries to leave, and the person trying to keep them in gets hurt. We usually say just let them go. We let them go, they wander. You know where they're going to go. Some people follow in the car. I have a family that the whole neighborhood knows that so-and-so is going to storm out of the house between 4 and 6. So everybody's in the front window waiting. Somebody will call them over and say, hey, why don't you come in for dinner? Another one will say, hey, can you help me with my yard work? Anybody can grab them along the path and bring them over to their house. And everybody knows where he is and he's safe. In assisted living facilities, what's nice is they like to storm, but if you design the unit appropriately, people can storm around the unit and not get hurt. The best units are circles, so they can storm in a circle. When people meet a dead end, they don't know what to do, so they're trapped. They don't know to turn around a lot of the times. You can have a stop sign, but they can't read the STOP anymore. You can put the stop sign symbol up, but they don't know what that means anymore. So when you put a dead end anywhere, it's destructive. So we say if you have anything that's a loop, that's so much better for everybody. Sometimes none of this works. So that's why we say we like to try everything else we can possibly think of. And my caregivers are the most creative people when it comes to finding ways to keep people busy. If it fails, if there's violence, if it's continually violent, if it's continually dangerous, we will start using medications to calm things down. Oftentimes, I don't start a new medication. I'll just look at whatever they take at nighttime and move it towards the middle of the afternoon, like 3:30, 4 o'clock, and that will smooth out the situation too. One of the things that can come up in Parkinson's are delusions, and these are called fixed false beliefs. And they usually happen in the context of dementia, but they've also happened in the context of the cinnamon dose being too high. They also happen in the context of bladder infections or pneumonia or pain. So that's why a full medical evaluation is necessary. So they are fixed false beliefs. They are as true as your own name. So if your name is Joe, everybody else is going to start calling you Bill. And you know your name is Joe, and you have all the documentation in the world to prove it. We, on the other hand, know that it's not, and we have all the documentation to prove it. And it causes distress on both sides because we're both right. But who's more right? The patient. The patient will always be more right because it's about them. We have people saying that their spouse is cheating on them. We have people stealing their money. We'll have this is not my home. I have so many men that built their own homes, carpenters, tradesmen, craftsmen that built their own home with their own hands 50, 60 years ago. It's not their home. Yes, it is, but no, it's not to them anymore. When this happens, you never argue. Never, never, ever argue. Like with Tom the son and Tom the brother, you get very stressed out. The patient gets very stressed out. And 20 minutes later, they've forgotten all about it, but you haven't. Your blood pressure is still up. Your heart is still racing. It doesn't work out. So what we'll say instead, we'll ask questions. So one of my guys had this, and I said, well, how do you know your spouse is cheating on you? And he told me in very great detail how she goes, and she says she's going to the grocery store, but she's really not. She's going on a rendezvous. And I'm looking at his spouse going, I know she doesn't have all this time to do that. So I just kept asking questions. And I said to him, I don't really think she has that much time to do that, do you? And he actually said, well, I don't know. Maybe she doesn't. Well, I'll have to think about that. I said, do you think maybe she goes to the grocery store? Well, she could do that, but she might have a rendezvous after. But see, nothing would get him off the topic. You express interest. So some people will say my spouse is cheating on me, and the first reaction is, no, they're not. Don't start the fight. Just say, oh, she is. Well, what's going on with that? And that gives them a chance to talk about it. And you can see just how deep those delusions run. How in danger is their spouse from jealousy, from violence, all kinds of things. I have a lot of people that say that people are stealing my money. So, okay, let's talk to the banker. Let's see what we can do to protect your assets, which doesn't go anywhere, but it's a problem and it's a solution. And they see the solution and they see that you care about them. Sometimes people really are stealing their money, which is why you need to have a family member there to make sure that that is really not happening. Another one is they're poisoning my food, and that's not really a delusion. Sometimes we are. Sometimes we are putting medications in their applesauce, in their pudding, in their coffee, any which way we can get it to make them take their medication so they feel better. So that's not really a delusion. When you have an argument with your spouse, you know how they tell you to cool down, to go separate ways for a little bit, come back and talk about it later and work things out. In these situations, we don't ever do that. We don't ever bring this up again unless they bring it up, because why? It just agitates everybody. I had the lady that her husband was a boxer, and he kept accusing her of having affairs, and she kept denying it, and I kept saying, I don't know how she's that busy. She's too busy to have an affair. Well, he punched her and knocked her out. The next day, he was placed in an assisted living facility. That's why we need to take a handle on this. Sometimes medications are what we need to do to make sure that nobody else gets hurt. I had another gentleman, interestingly, he was a Pacific War veteran, but he said the Nazis were out to get him. The Nazis were so out to get him that he almost threw himself off of his balcony. And we could not for the life of us figure out why this happened. But his family said it happened overnight. And when people say it happens overnight, that's my trigger to doing a delirium workout, checking everything. We checked all of his blood work and everything was fine, because that's what usually it is. Usually blood work is fine. I said, something's still not right. Let's x-ray everything that can be broken. And we found out that he broke his hip. We have no idea how. He didn't have the wherewithal to tell us how, but the pain was so bad that it was causing this delirium that the Nazis were out to get him when he had never even set foot in Europe. In these cases, outside of the delirium, when we have a delusion that is becoming more dangerous, we need to medicate. We need to medicate for the protection of whoever the delusion is against, as well as the patient. And I'll talk about our options in a little bit. Visual hallucinations are seeing things in the environment that aren't there. They're never psychiatric. And I'll tell you that because it's not a part of bipolar disorder, it's not part of schizophrenia. People will say, oh, that's not true, this and that, the other thing, because my patients with bipolar disorder and schizophrenia hear things, or they have delusions, or they have paranoia. But for them to actually see stuff that's not the environment, it's not my game. That's why I start looking for other things. What can we do to help this patient and make sure that something else is not going on? If this is new, we will always call the doctor. Is it a delirium again? Is it a medication problem? Interestingly, when you have Parkinson's and you take Sinemet, your dose of Sinemet can do this if it's too high, or if you don't follow the instructions like the doctors say to go up by so many pills every week. If you rush the dose, you will get this. But you also usually get the dyskinesias, where your trunk will dance or your arms will dance outside of your control. They usually go together, but not always. Sometimes later in the course of Parkinson's, it can signify the appearance of Lewy body dementia. And Lewy body dementia it's tricky because with Alzheimer's, you see the memory changes first, and sometimes you get behavioral changes, and then sometimes you see things and hear things towards the end of Alzheimer's. In Parkinson's, you get the motor changes first, and then you get the memory changes, and then you see things. That's how Parkinson's can progress. It doesn't have to, but it can. In Lewy body dementia, all three of those things happen. And then you throw motor symptoms on top of it, and the motor stuff doesn't respond to Sinemet like Parkinson's does. So that's where we look at Lewy body dementia, and that's where I get involved and try to find out how can I help this patient with different medications. Interestingly, Aricept, which is generically donepezil, this was designed for Alzheimer's. It doesn't work very well to preserve memory. I don't honestly know how it got out of the FDA, because in the test studies, they gave patients a 122-point question scale. And if you took Aricept, you only got 3 more questions right. However,
You're frozen.
Hey, Dr. Boore, you seem to be frozen right now. Yeah, we can't hear you. I don't know if it's your internet or.
I don't know. I can hear you. Okay.
You're back.
I can hear you now. You're good. You're
Okay.
back. Okay. Hey, folks, it happens on Zoom. Occasionally, it happens on Zoom. People get frozen, so just sit tight and she'll come back, okay?
Can you start back at where you were saying about Lewy body dementia? That's where it froze at, and that's what I'm kind of interested in, just because I don't exactly know what it is. I know we don't have it, but.
Okay. So can you hear me now?
Yep, we can hear you now.
So in Parkinson's can transition to a Lewy body dementia picture. So Alzheimer's dementia progresses as memory, and then it's mostly memory, and sometimes you get behavioral disturbances towards the end of Alzheimer's. In Parkinson's, you get motor symptoms first, and then you get memory symptoms, and then you can have visual hallucinations. It's very linear. It follows a pattern, and it's very predictable. Lewy body dementia is a separate entity, and there's overlap with Parkinson's. There's overlap with all the other dementias, but with Lewy body dementia, it seems that you get everything all at once. You get the motor symptoms that kind of look like Parkinson's, but aren't really, but they don't respond to Sinemet, but they kind of do for about a week or two. The memory issues come in, the visual hallucinations come in. Lewy body dementia can look like delirium. That's why we always do the full medical workup to make sure that we're not missing something. Interestingly, when I have my Parkinson patients start telling me that they're seeing things and it's not due to the Sinemet being too high, I will start Aricept. And Aricept was for Alzheimer's to preserve memory. It doesn't really work that great for preserving memory, but it can really knock out these visual hallucinations. Sometimes it doesn't work though. So I'll use Seroquel or quetiapine or clozapine, which is Clozaril. And they were designed for bipolar disorder and schizophrenia, but the doses that we use for that are fractions of what we do for people with schizophrenia or bipolar disorder. Sometimes we can't not make these visual hallucinations go away. But what we can do is take down the anxiety about them. Sometimes they really bother people. People don't get stuff done, they don't sleep, they don't eat, but we can help with the anxiety around them. The other thing too with visual hallucinations is we rule out a syndrome called Charles-Bonnet. And when you have macular degeneration and other visual problems like extreme cataracts, your brain starts to miss input. So it will start making stuff up. So your eyes are still working, but your brain is not getting the signal it's used to. So it will put a potted plant in the middle of the room. It will put children having tea with their kitty cats in the front hallway. And patients with Charles-Bonnet know that those are not real. They will say, my mind is playing tricks on me. I need this to stop. They'll call their eye doctor. When it comes to Parkinson's or anything else but Charles-Bonnet, it terrifies people. It freaks them out. We get the phone calls, something is wrong. There's a dragon in my house and I don't know how to get him out of here. The dragon is very real. They can see the smoke coming out of its nostrils. They can see the sharpness of the scales. And that dragon is very real. It's not going anywhere. Whereas Charles-Bonnet, they say, oh yeah, that dragon's back again. Well, I'll just go in another room and he'll be gone. What do you do when this happens? Well, after you call us and we try to figure out that this is a legitimate symptom and we're trying to get a handle on it, some people respond very well to just saying, oh, it's okay. I'm here. I'll protect you. That dragon's not a big deal. And then we take them into another room. We pat them on the shoulder. Sometimes just a simple touch on the arm is enough to distract them and reorient them back, and the visual hallucinations go away. Sometimes patients are very, very, very upset, and we just offer reassurance. I know you're worried. I know it's very strange to have a dragon in the house. I know it looks like people are breaking into the basement. I know this is frightening. We'll fix it. We'll take care of this. We'll do the best we can. Distraction is the first thing that we'll do. We'll offer music, offer a drink, offer to go for a walk, anything to get away from wherever that situation is. Some people will say, am I crazy? Of course, you always say no, but because they're not. But they'll say, do you see that? And we have to say, no, I don't see it, but I know you do. And that validation is enough. They'll say, oh, okay, so it's just my mind playing tricks on me. And I'll say, yes. Or if you start arguing with somebody about nobody's breaking in the house, there's no children here. It again starts an argument with something that they know to be true, but you know to be true as well, and it doesn't meet up well in the middle. What we always do when this first starts happening is we always look at the environment. Is there a coat rack that looks like a person breaking in the house? Is there some kind of shadow somewhere from something? We look at everything that we possibly can. I have patients that have very, very advanced dementia that don't recognize themselves anymore, and the mirrors are terrifying. Who is this old person? Why are they in my house? And it's heartbreaking because it's them. They don't recognize themselves. So what patients, spouses, and caregivers will do is they will wrap those mirrors. Some of them are too big to move. You've seen the really heavy ones. They will wrap them in gift wrap, or they'll put blankets over them, anything to cover up the reflections. Sometimes it happens with windows. So the people will put the thin gauze curtains over them. So the light still comes in, but the reflection is broken. Auditory hallucinations are hearing things that are not there, like voices, people's footsteps. It could be music, it could be animals, dogs barking. If this is new, call us. If you have evaluated the environment and there's absolutely nobody upstairs stomping their feet, you know how when you live in an apartment, you always have the person upstairs that's always noisy at night? It's inevitable. That still happens when you're living in your 2-story house by yourself. There's somebody up in the attic stomping around. You have to make sure that your hearing aids work. If mine don't work, I can't tell you what that sound is outside. So that's how it is on the inside. If you're hearing something but you don't know what it is, your mind is going to fill in the blank and it may not be the most accurate. We always offer reassurance. Yes, that's scary, or oh, I don't know who is upstairs. Because sometimes just the fact that you're validating them is enough of a distraction that they can move on to something else. Interestingly, when you move from I always talk about the environment. When you move from something that's not very well lit into a well lit room, not just turning on the lights of where you are, but moving, that is enough to make the hallucinations go away. With schizophrenia and bipolar disorder, this is not the case. You can take them every which way and go anywhere you want, but those hallucinations will still be there. And again, you want to respond honestly. Did you hear that? And my family knows I don't hear anything. So I'll say, no, I didn't hear that. What did you hear? And my patients will tell me, oh, I heard him. He's upstairs. Did you hear that? He's upstairs again. So I have to know who's upstairs. What's going on? Where is the spouse? Where's the caregiver? Where's the son? Where's the daughter? Where's the loved one? What is going on? Sometimes it is very real. It is a very noisy neighbor upstairs. Sometimes it's nobody. Apathy happens in Parkinson's. It can happen at any stage. And I had a neighbor, we called him Mr. Ken. He was the sweetest guy. His, you know how you get the masked face with Parkinson's? We didn't know as children that's what was going on. So we always said, why doesn't Mr. Ken smile? He sees us, he waves, he says, oh, hello, girls, but he never smiles. So my dad would tell us, oh, he smiles on the inside. So eventually Mr. Ken got to sitting around in his lawn chair in the garage, and that's all he did all day. So my dad would go over and say, hey, Ken, let's go do this, or hey, Ken, let's go do that. And Mr. Ken would say, no, I'm not up to it today, or no, thanks, maybe tomorrow. So my dad took to talking to his wife, and his wife says, yeah, now that he just sits there. I can't get him to do anything. He doesn't want to do anything. He doesn't care about anything. He used to love going to church. I can't get him to church. I can barely get him out of that lawn chair. And it turns out that he actually did get a bed sore from sitting in that lawn chair on his bottom, and that was not good. So what did Mr. Ken do? He just got a cushion because he was going to sit in that lawn chair. But everybody else wanted him to do stuff. This is one of the hardest symptoms to treat because it becomes hardwired. It doesn't, like, there are a lot of changes happening in the Parkinson's brain, and this is one of the ones that we have to fight with the most. What we do, though, is we get people moving. We give them marching orders. This can lead to people not eating, not participating in physical therapy, not going out with their loved ones, not being social. So what we do is we do schedules and routines. Every day, you're waking up at 8 o'clock. From 8 o'clock to 9 o'clock, it's shower and get dressed and shave. From 9 o'clock to 10 o'clock, it's breakfast. So it's constantly on a schedule, constantly on a routine. That's why I talk about schedules and routine and keeping it boring, because that's how we want to do it. We want to keep the hum of the machinery. If you ask somebody, do you want to go for dinner? And they have apathy, they'll say no. So instead of saying, do you want to go to dinner? You say, let's go, it's time for dinner. And then I've seen this, people say, all right, let's go. So I've done it in my office with some of my patients, and I would say, so are you ready to go home now? And they'll say no. I'm like, okay, that's fine, they can sit, I don't mind. I like talking to my people. So a couple minutes later, I say, all right, well, let's get you on your way. And they'll stand up before me and they'll go out the door. So it's very interesting to see just a few minutes difference of how I've rephrased the question, and off they go. Sometimes no matter what you do, you're not going to get anywhere, and it's frustrating because it's painful to watch somebody sit there all day and seem like they're not interested in the world. Ritalin, which is generically methylphenidate, is very good for this. It's a very pure medication. It goes only to the frontal lobes where we need the activation, and it helps people get their appetite back. It helps them get going in the morning. The doses that children take are like 40 milligrams twice a day. I would never, ever, ever give that to one of my Parkinson's patients to start. That is way too much. Some people, all they need is 2.5 milligrams in the morning, and they are off and running for the rest of the day. Sometimes people need a booster after lunch, never after 4 o'clock, so it will keep them up, but it gets them going. I had a patient call me once, and she said, my husband tore out a bush. And my first thought was, oh no, was that supposed to happen? And she said, yeah, I've been asking him to take out that bush for 3 years now. He started your medication yesterday, and today he ripped out that bush. Oh, okay, all right, well, that's what we wanted. We wanted him to get moving again. Depression. Depression is one of the biggest things in Parkinson's that we treat. About 80% of my people with Parkinson's get depression. And depression in Parkinson's is very different from depression in anybody else. And that's why I want to focus on this. All the other symptoms that we talk about are a part of it, but depression is the biggest. I can always be guaranteed that my patients will get it to a different degree. There is the depression that comes with the frustration of not being as healthy as people once were. It's the frustration of not being able to do the things they used to be able to do. It's the frustration with their body changing, with all the doctor's appointments, with all the medication trials. It is very frustrating and it's very depressing. Depression in Parkinson's, though, is very different from the sad mood, loss of interest, sleeping all day, not eating that we see in the younger population. It's a loss of interest for sure, but it's not necessarily sad. If you ask people on our usual rating scales, do you have a sad mood? They'll say no, they do not feel sad. There's nothing sad, depressed, any of those adjectives, they don't feel it because it's just not how it is. If you ask them, do you feel hopeless? Do you feel helpless? Do you feel guilty? Do you feel that you're a burden? Then we start seeing the tick, tick, tick. Yes, that's me. I feel hopeless about my situation. I feel helpless because I can't do anything about it. I feel real guilty. I'm sure I did something to myself when I was younger. A lot of people like to blame the 60s. The 60s had nothing to do with this, trust me. A lot of my patients feel that they're a burden. Their loved one has to take time off of work to go to the doctors with them, to drive them here and there, to do the simple things that they used to be able to do. That is a huge, huge marker for me for depression. People with Parkinson's have trouble with eating or sleeping as it is. Eating because of swallowing or constipation, or the fact that your taste changes. Sleeping because you get the REM sleep behavior disorder and you act out in the night, you don't get that good solid sleep that you used to. Those intensify. So that's why we ask about little things like that. How are you eating? How are your bowel habits? So people always ask me, you're a psychiatrist, why do you care about people's bowel habits? Well, in Parkinson's, I care a lot because I need to know, are you moving them? Are you eating? What's going on? Some people that have depression will get into alcohol or substance abuse, and that creates a whole host of other problems because alcohol interacts with every single medication that you take, even your vitamins. It interacts with everything. Or they'll start using marijuana heavily. Some people use marijuana in Parkinson's just to like puff here, puff there, but it gets to the point where that's all they do all day, so they don't participate in life anymore. Another interesting feature of Parkinson's depression is the anxious distress without being anxious. What does that mean? You know how you get the nervous Nellies that wring their hands at Chicken Little? The world is coming to an end, the sky is falling. I can't stop worrying. I can't turn off my mind at night. This is not it. That's the anxiety of the younger population. When you're over 60, it turns into an unsettledness, an uneasiness. I gotta move. I gotta do something. It's that I should. And it's a constant like a hum. People tell me it's like I feel like I'm humming, but I don't know why. I'm not worried. When you ask them, are you worried? I'm not worried. I'm financially secure. My kids are grown. My spouse is the greatest spouse I've ever had. I have no worries. But you can see that there's something humming there, is something moving, and that's the depression. You do get anxiety. Parkinson's people can get pure anxiety unrelated to Parkinson's or in the context of because you don't know what the future holds. Why am I not responding to my medication? Why did I have too much of a response to my medication? What is the trajectory? What is my life going to be like? How do I plan for the next 3 years? That's definitely a part of it. It's the hand wringing, it's the stomach upset, it's the unable to control worrying, it's worrying about different things. My kids, my spouse, my finances. This is very different from that anxious distress because the anxious distress is vague. There's nothing they can put their finger on. But in this anxiety, we can talk about it, we can get it, we can grab it and say, okay, this is what we need to do. Somebody raised your hand. How does that work? If you have a question, can you put it in the chat box? Because if you can put it in the chat box, then I can make sure to get it.
I'm not seeing it, but if you have a question, please put it in the chat box.
Okay, so I'll keep going, but please do ask questions.
Okay.
Another big concern in anything that I deal with is substance abuse. So if it's depression in younger folks, if it's Parkinson's, if it's whatever it is, I always ask, because sometimes this is making the situation worse. Some people are afraid to tell us that they're drinking so much because they don't want to be yelled at. We're not going to yell at you. The substance abuse, something is fueling this. Is it depression? Is it anxiety? Is it a hopelessness? Let us help. Let us help with that. So we will work it out together. Interestingly, the substance abuse is not so prevalent in my patients as it is in their caregivers. Caregivers have a 60% likelihood of using alcohol to cope and overusing alcohol to cope. So then that makes them a less efficient caregiver. In the patients themselves, the use is often less because if they're taking their medications, they don't want them to interact with the alcohol. So some people will tell me that if they drink, they won't take their medications. That doesn't help either. It's not great, but it's not the worst. Interestingly, there's no major change in use as you get older or as your condition changes. So some people have had a drink every night and that's just how it's going to be and they're not going to change. I have had people that have had alcohol issues for 40 years and they're going to keep having them. Interestingly, I have a lot of patients, especially military veterans, specifically Vietnam era, that have been sober for 40, 50 years. And that's remarkable. But I always ask. And there's treatment. There's nothing embarrassing about having a substance abuse issue. We take care of it. Okay, so what can we do about all of these? There is hope, there is stuff we can do, and that's why we ask these questions. If you're not being asked, please tell a doctor. Please tell somebody so we can work on this with you. People like coping strategies, and some of them are what you already know. It's the regular sleep schedule. It's trying to keep that sleep routine so your body knows what to expect the next day. Regular exercise is one of the other best things you can do. So that way you have your routine. You wake up at a certain time in the morning, you go for your 2 or 3 mile walk, you come home, take your shower, eat breakfast. Your body and your mind know what to expect for the rest of the day. If you're getting up at 5 o'clock one day, sleeping until 11 o'clock the next day, it's really unsettling to your brain. Your brain likes to keep things routine and boring. And the more we can do that, the easier it is to heal and take care of other things. That is so the question is, how do you handle someone who insists on doing something that isn't safe? Yes, and we can definitely send these slides out too. So let me get the questions here. So one of them is, how do you handle someone who insists on doing something that isn't safe? That's huge. I have a bit on driving in a little bit, so I'll make sure to touch on that. Another question is, what are some of the less severe, not dementia, cognitive difficulties with Parkinson's? That one is attention and executive functioning. So the ability to multitask, to carry out a project from start to finish, that can become impaired. We have a term called mild cognitive impairment. So one of your memory domains is not 100%. So like you may forget people's names, but everything else is perfectly fine. Or you may have trouble balancing the checkbook now, but everything else is perfectly fine. So as long as it's only one domain and it's not affecting or ruining your life, we would call it mild cognitive impairment, and that's not a dementia. That's different. So I would definitely get to the unsafe stuff in just a few slides. That's actually a really huge report. So regular contacts with others, and I put the adverb in this time, safely, because with COVID-19, we really need everybody to be safe so this can hurry up and go away. Regular contacts by Zoom, these meetings are fabulous. You get to talk to people who are in a similar situation or in different stages of a similar situation, so you're not alone. House of Worship was fantastic. This was all pre-COVID. With COVID, we've had to make some adjustments. House of Worship, these are some of the most supportive places for my patients. Some of them not so good. Some of them people feel very much judged, or if they have depression or anxiety, it's a personal failure, it's not a medical issue. So the House of Worship can be a mixed bag, but usually it's really good because you have supports. You have committees at these places, like my church has a nurse group. they would go out to your home and check on you, make sure that you're okay if you were on the prayer list. Another big coping strategy is meditation. I myself can't do this. I can't sit still long enough to focus on the waves of the ocean crashing on the beach, and I just want to just like poke my eyes out. But some people really like that. Some people can sit there and do imaginative thinking like that. They can focus on a word and clear the thoughts out of their mind. And it's for some people and it's not for others. Reading is fantastic. You gotta make sure your eyes are so good. You've got your glasses, you've got good lighting. So when the reading doesn't go as you want it to, I need more books on tape or iPhones, Kindles. They have all kinds of different strategies now to make sure that you can still get a hold of a book. Music is phenomenal. If you can play an instrument, we always ask people to play. Make it part of the day. So when we say structure and routine, from 3 o'clock to 4 o'clock is your piano time, it's your guitar time. It's sit there and listen to the records or the iTunes. I have a patient who has a whole room in his basement that's just records. And that's what he does. For an hour every day, he'll go and listen to some of his records. And I think that's awesome. Art, people paint. I heard of a painting class when I first started here at Ford. And it's not going on now, but I don't know what happened to it. But people loved it. They had no talent whatsoever, they told me. But it's just the meditative actions of it, the creating something on a canvas, giving a different purpose. And they absolutely loved it enough that they bought their own supplies and are still doing it at home. Housework is a great coping strategy. I'm sure there's a spouse that's not happy with me right now, but housework is fantastic. It keeps you physically moving. It keeps the house clean, and when I say clean, free of debris, free of things you won't trip over or knock over, or things that could be dangerous. Outside housework, we always tell men over 60, please do not climb on ladders anymore, because 90% of falls in older men over 60 are because they fall off a ladder. So please don't do ladders. If you want to do power tools, that's fine to the best of your ability. If you want to garden, it's amazingly therapeutic. Weeding, planting, cutting the grass, anything that you can do safely. There are apps on iPhones and Androids. Every little gadget you have has an app store, and there are meditative apps. There are anxiety apps, depression, or even one for sleep. The one that the VA developed is called Cognitive Behavioral Therapy for Insomnia, and it's got the VA logo on it. That app is phenomenal. It tracks your movements through the day. It helps you figure out where you can sleep better, different things, just little things that you didn't even think about for your sleep. I really like that one. I tell everybody, even if they don't have sleep issues, to look at that app. Concerned about tremors with reading and blurring. Yes, that is huge. I have had patients try to fill out my paperwork for me and they say I can't do it because the paper keeps moving. So it's got to be so frustrating to have the newspaper be bouncing around. That's why we like, there are certain devices that for like the Kindle or an iPad, you can actually mount it so you don't have to hold it in your hand. Some people, depending on where they're sitting, will put a pillow on their lap and put the device or the book on the pillow. And there's a weight, it's a rectangular weight. It's not too big, it's just enough that it holds the book down. Because if you put a book down, the spine closes and you lose your spot, and then you gotta find it again. It's really frustrating. But I'm trying to remember what the name of that thing is. But it's a rectangular weight and it'll hold the book open for you. Some of them are clear, so you don't lose the words on the page, so you don't have to keep moving the weight to read around it. Can't remember what it's called though. So no, that is a very big issue. Tremors can really mess some things up like that. They're enjoyable. Like painting. I thought my patient that painted, I asked them, how do they do that with their tremors? And they say for some reason it just helps. They don't mind the tremors. They've given up on that perfectionism. So when you for the VA sleep app, when you look at it in the App Store, you will see the VA logo. It's just really like that, but it's their logo and it's red, white, and blue. If you can't find it, I'll help you. I can show you on my phone. So medication. So this is what doctors do, and here's a secret. Don't tell it other people. We don't actually like to prescribe medication. if we are prescribing a medication, it's because it's come to that point where we've tried everything else we can possibly think of, or the families have tried everything else. I have families that have the most creative caregiver, comes up with every non-medication strategy in the book, and then they start failing or they start changing, or it's too stressful to keep up. So if I'm prescribing a medication for something, it's because we need to now. When it comes to medications, we'll use the usual suspects. So like our Zoloft, Prozac, sertraline, fluoxetine, those are the generic names. But the doses may not be like you see in the younger population or the patients that don't have Parkinson's. There is no such thing as a homeopathic dose, and this is what really gets me boiling. If there are any of my patients here, don't out yourselves, but you know how I get on this topic. So I will have a patient that has depression or anxiety, and I will say, here's some sertraline, which is Zoloft. Let's start at 12.5 milligrams. Everybody else in the world starts at 50, but because of the fragility and the differences in the Parkinson's brain, I don't ever start at 50. It will knock everybody over. It will give them every side effect in the book. Then they hate me and they hate my medications. They don't come back and they continue to suffer, and it's not good. So the doses we start at are way, way, way lower than anything else we would give anybody else. And we'll go up. You should keep going up until you either get side effects or you start getting a response. So with something like sertraline, I would say, okay, here's 12.5 milligrams for the day. 2 weeks later, we're going to go to 25, and we stay there for 2 weeks. Then we go to 37.5. We stay there for 2 weeks. I have patients that take 12.5 milligrams. I have some that take 300. So anywhere between 12.5 and 300 is whatever works for the patient. And if they don't like it, we switch it. If it's causing trouble, we switch it. There are some creative dosing strategies that we'll use too. So for sundowning, some of our medications help people sleep at night, but not enough to make, we don't ever want to knock people out. That's a horrible thing to do, and it's not legal. So we want to help people relax enough that they fall asleep on their own. Some of our medications can be used in a lower dose to offset some of the afternoon behaviors. So we'll do that. So I'll say, let's split the dose. The total dose for the day of, say, a medication called trazodone, which is Deseril. It's a very lousy antidepressant, but it helps people get sleep. So I'll say, let's try 12.5 milligrams around 4 o'clock, and then 25 when you go to bed. The dose most people start trazodone is at 100. So to do 37.5 split by hours apart is not horrible. It helps what we need it to help with. For depression or anxiety, it's like I said, it's the usual suspects. It'll be a much lower dose. What I like is I like to kick it back old school with tricyclic antidepressants. They came out in the 70s, and that means we have 40 some years of safety data on them. The newer medications like Frentelix and some of the ones I don't even know, Rexulti, which is an antipsychotic, they just came out last week. I have no idea what the long-term effects of them are, and I don't want to find out. I know that the amitriptyline and the nortriptyline, all of those, I've got 45 years of safety data, so I can tell you with confidence, this is why I'm picking this medication for you. And the starting dose for just say nortriptyline is 50 milligrams. I never ever do 50. I start at 10 because I've had people that get remission from their depression or anxiety at 20. I had a gentleman that got it at 10. Like, okay, all right, that's enough. That's what your brain is asking for, and that's what we'll do. There's an interesting combination in Parkinson's called mirtazapine and venlafaxine, which are Remeron and Effexor. Because they're very different from all the other medications and they're very different from each other, but together it's like a 1 + 1 is 3. The mirtazapine helps people sleep at night. The side effect is sedation, so people sleep really well at night. They hate me for about the first 3 days because they really do sleep all day and all night. But around the 3rd day, something clicks and they get up in the morning, they feel better, they've had that good sleep. But sometimes they still need the help with the depression or anxiety. So that's where venlafaxine comes in. The two of them together don't interact. They don't interact with your medications that you take now, and people feel a lot better with them. Another class of medications that we use for some of the other behavioral issues we talked about, like delusions or hallucinations, are antipsychotics because those are psychotic symptoms. The way they're coming forward in the brain from schizophrenia compared to Parkinson's are very different, but it's the same symptom. So with somebody with schizophrenia, I can give them a medication called quetiapine, which is Seroquel, and it's the least likely suspect to make motor symptoms worse in Parkinson's patients. But in schizophrenia, my doses are 300, 600, 900. In Parkinson's, it's 12.5, 25. I mean, it's not even a sprinkle. I actually feel bad because I had a patient's family bring in the medication one day. They said, Dr. Boore, we can't cut these to 12.5. And I said, well, why not? Why is it so hard? They brought the medication, and honest to God, that medication is the size of a cupcake sprinkle. And here I have been asking them for months to just cut it in half. So I ended up changing the prescription entirely because were they getting 12 and a half? Were they getting 20? The other little bit that crushed was 5. So it wasn't consistent. But that's just to compare the dosing between the two conditions and how we use the same medication for the same symptom, just differently. Clozaril is also known to not have that many motor conflicts with people with Parkinson's. That's why we'll use it. Again, the doses are very low. My people with schizophrenia take 800 milligrams. My Parkinson's patients take 12.5. I even had a guy that we crushed it to make it 6.25 once. It was really hard to do it, but that was all he needed. The risk with those both are being too tired. So when people are too tired and they have Parkinson's, they fall. So we really want to make sure that that's not happening. Another medication that's come out is pimavanserin, which is Nuplazid. And I can tell you, I don't like it at all. I don't think it does what it was designed to do because the brain is making the same symptom but different ways versus in Parkinson's versus schizophrenia. It's going after the way the Parkinson's brain makes that symptom come up. And I have not had anybody do really well with it at all. My friend on the East Coast had 3 people die from it, sudden cardiac arrest after the first dose. She will never, ever, ever prescribe it again. I actually talked to the manufacturer, and it was a total gaslighting situation where they said, Dr. Boore, you don't know what you're doing. I said, thanks, but I don't like it. Let's see, I've got some questions I'll get to. So one of the questions that comes up with these medications is safety. So Seroquel and Clozaril and our risperidone, they come with a black box warning in dementia. And if you look at the actual study, which I think do I have it in here? Let me see. No, I don't. I should have put that in here. So there was a study that came out a couple years ago that said, if you take any of those medications that I answered in the context of dementia, you will die from sudden cardiac arrest. If you read the actual study, the risk of sudden cardiac death when you take those medications is 4%. And they can't guarantee that the medication even caused that problem. In that study, the placebo group had the same problem at 2%. So the actual risk is 2%. But if you have a 100% chance that somebody is going to get hurt because of their behavior, what are the odds? When I explain this to families, they're like, we don't care. We need to do something to keep everybody safe. So when it comes to safety, it's always relative. We always talk about the risks and the benefits with everybody to make the best decision for you or your loved one. Sometimes people will be concerned about heart rhythms when it comes to Seroquel or Clozaril. It's usually not a problem. If you when I say usually, it's because we look at every single medication that you're taking. There's a stigma associated with all of our psychiatric medications, and I mentioned that at the bottom, that stigma can kill because people won't want to take our medications because they're psych meds. Well, that's great. You wear eyeglasses for your eyes, and nobody says anything about that. You wear your hearing aids, and nobody says anything about that either. But to take a medication to help with your anxiety or depression or any of the other symptoms, and just because they're psych meds is awful. These medications can really be life-saving. Some people will err on the side of caution and get an EKG before they prescribe. I personally don't unless there's a problem. I've only called cardiology twice in my whole entire life, and I can tell you exactly who that was for because I wasn't sure. So in medical school, that's why you want a doctor to do this, is in medical school, we learn how to read those EKGs. We need to look at them. I can't do it with the skill of a cardiologist, no, but I can do it enough to say that this is not a good idea or this is going to be okay. Aricept, which is donepezil, it was, like I said, it was designed to slow the progression of memory loss and Alzheimer's. It doesn't really, but it buys you time. It buys you 6 months. So if that 6 months means that you're 6 months home with family, as opposed to 6 months in a nursing facility or a living facility and with 6 months of expenses, that's a good 6 months. It changes the memory when you stop taking it. So when you stop taking it, the memory will change as if you've never taken it before. Interestingly, for my hospice patients, every single bottle, every single order I write says do not discontinue without talking to Dr. Boore first. Because if you have somebody who's on hospice or dementia and you take this medication away, everything blows up. And it is the most awful thing to witness. People start crying, they start whimpering, they start picking at their clothes, they're agitated, they follow people around if they're still ambulatory. If they're not still ambulatory, they're pulling at their sheets. It's so sad to watch it. So that's been happened enough to me that they call me and they say, so-and-so is agitated. You have to give them a medication. And my first question is, where's the Aricept? And the reply comes back to, oh, we stopped it because, you know, it's for memory and they're on hospice, so we're removing all unnecessary medications. And that's why I started putting that out right on the bottle, right on the orders in the nursing homes, because I said, stop doing that because I can't fix that. I can't help that situation. The Aricept needs to stay until the very day they go home. What they'll do then is people will say, well, if Aricept is the only thing we stopped, we should just restart it. That doesn't work either because then you get all of the side effects. So I always tell anybody who takes it when I prescribe it for them, please don't ever stop without talking to me first. If it causes problems, we can try to fix it. If it's working, it's hard to tell if it's working as you go forward. It's not like an antibiotic where when you have pneumonia, you take an antibiotic, you get better as the days go on, your oxygen levels go up, you feel better. With this, it's a look back. So we'll say, well, how was Dad at Christmas? Well, how was he at Thanksgiving? Well, how is he on 4th of July? So we compare and contrast major holidays. For Jehovah's Witnesses who don't celebrate holidays, we'll try to do current events. So like all these horrible current events last year, we'll say, so what happened when the California fires broke out? How did that compare to the election? So we try to figure out time and look back for that one. Memantine and Namenda are also supposed to be memory-sparing agents like Aricept. Again, their effectiveness with that is just all right. But I will say that it does help my patients with Parkinson's with some of their depression and anxiety, believe it or not. I have some patients that have anxiety in the context of memory loss, and I won't use my usual sertraline, any of those. I'll actually use Aricept or Namenda, and it knocks out the anxiety and they feel a lot better. One of the questions is people take the same dose of Aricept and should they increase it? But there's no data out there to support going over 10 milligrams a day. Anything over 10 milligrams usually, I say usually, causes more side effects than good. So we'll actually get in a fight about this, me and the neurologist. The neurologist will say, let's go to 15, let's go to 20, let's do 23 milligrams. And I'm like, no, we're going to stay at 10 because it's affordable and it doesn't cause trouble. The 23 milligram dose of Aricept was I don't know how to say this nicely, a pharmaceutical scam to recoup money. Aricept went generic. And when it went generic, they lost their money. So what did they do? They rebranded it. So instead of making it 25 milligrams, because you can make 25 milligrams out of generics, they made it 23 milligrams. It's expensive and it doesn't work any better than the generic 10 milligrams. See, there's another question here I want to make sure I get. I don't want to forget anybody. So one of the questions is, what don't I like? And I think that's in relation to Nuplazid. And I don't like that it doesn't work. It's been touted as the cure-all. It's been touted as it's going to knock out these visual hallucinations and it's not going to affect your Parkinson's motor symptoms. And I have not seen that. I have seen people's dyskinesias get worse. I've seen them fall. I've had one of my poor patients. He is just the nicest guy. He still has the visual hallucination. It's still there, and he just doesn't care about it. But now he's got this trouble where he cannot sit up straight. He does have a little stoop anyway, but he can't sit up straight, and he's constantly rocking in his wheelchair. So what happens? He falls forward and knocks his head. So that's part of the reason I don't like it. I don't think it works, and I don't think it's worth the payoff. I haven't, and so like I said, I'm in the neurology clinic, so I'm seeing a lot of these patients, and I'm not seeing anybody really running home and saying, yeah, this is the best medication ever. Somebody commented that Nuplazid's advertising is great. It sure is. They want to make money. They want to help. Their intent is, I think their intent is right. They want to help, but it's just not going the best way. We don't want people to get worse off. We want to help people and make their life better. Another question is it important to diagnose dementia with Parkinson's or just try to treat it? So yes, because what you want to do is it's important to diagnose dementia in the context of Parkinson's because we want to make sure it's not medication interactions, it's not a delirium, it's not an infection. Parkinson's dementia is it's frustrating because you already have to deal with the motor symptoms and now you have to deal with the memory symptoms. So it's very frustrating. The rest of the question is, what do I recommend for confusion for someone prone to visual hallucinations? And that would be the Aricept, the donepezil. It can make people feel more alert so they don't feel as confused, and it can actually, that is one of the few things that can make visual hallucinations go away. It works for a while. I mean, it's not that they go away forever, but it can work for a very long time. One of the things I wanted to show you was the Beers criteria. I don't know if you've heard about this. They used to hand out the criteria when I was in the neurology clinic, and I had to ask them to stop because people would bring the Beers criteria to me at the next appointment and say, well, Dr. Boore, you're giving me a medication on the Beers criteria. And what this is the American Geriatric Society, rightfully so, put a list of medications together that said these could harm our older patients. They can harm our patients with Parkinson's or Alzheimer's. And that's not what we're in the business to do. We're not trying to hurt people. If you read the list of what's in the Beers criteria, it's everything every patient ever takes in their entire life. So it's not, to me, this is not useful at all. So if you see here, here's Parkinson's disease, and I'll say these medications can make Parkinson's worse, and that is very true. These medications are structurally similar to my antipsychotic medication for schizophrenia and bipolar disorder. And then it shows you the articles that said that, which is great because then I just click on that link and then boom, I've got the actual article it came from. But if you go up, dementia and cognitive impairment, say anticholinergic, benzodiazepines, Zolpidem, which is Ambien, which I'll talk about next. So here it says avoid due to adverse central nervous system side effects. Sometimes you need these medications. Sometimes they're doing something else for somebody. Antipsychotics, chronic and as needed use. I just talked about this with hallucinations and delusions. So this is where it makes me look like a liar, and this is where I get in all kinds of trouble with my patients saying, well, the Beers criteria says they do, but at the same time, the Beers criteria says right here, avoid them unless non-pharmacological methods have failed and a patient is a threat to themselves or others. If you go up, metformin is on here. All the pain medications, aspirin, Motrin, naproxen, insulin, sliding scale. So that's why I look at this with like a crushed grain of salt, because your doctors are already taking your best interests, the risks and the benefits into consideration when they offer you a medication. This just kind of destroyed everything we've ever done, because we want you to trust us. We want to work with you. We do not want to hurt you. And this comes out and says, everything in the book that you prescribed, Dr. Boore, is going to kill me. So if you ever have a concern, please talk to us. Talk to the pharmacist, any of us. That's what we're here for. We went to school forever to do this for you. Where did my presentation go? Okay. So now, why don't we like Xanax? Everybody asks me for Xanax. Please, Dr. Boore, I have anxiety. Can I have Xanax? The nursing homes, please, Dr. Boore, they're so agitated. We don't like it. Ativan, which is lorazepam, Xanax, alprazolam, Klonopin, clonazepam, Valium. Everybody loves Valium. Ambien, Zolpidem. These medications are the one that almost everybody agrees on, that they're not good for anybody. But there are certain situations, like if you're public speaking or if you're in an airplane and you fly twice a year and it gives you the most horrible anxiety, you have Xanax for twice a year. We don't like chronic use of it because it can make your memory really dull, make you feel like you have dementia. There are 2 articles that came out within the last 2 years. One said that these medications cause dementia, and another article said that no, they don't. So the jury is still out, but I can tell you that when I have patients that have taken Klonopin or Valium for 20 some years, and I start peeling off the layers, I get a brand new person. I get their memory back. I get their spark back. Sometimes there are situations that call for it, like in hospice situations. Hospice is a completely, totally different situation. It's a whole conference, a month-long conference of its own, because when you get to hospice, it's anything goes. Whatever you need to do to help that patient be comfortable, to help their loved ones. At that point, whatever it takes. There are so many rules in medicine will say you cannot use a muscle relaxer with an opiate medication, with my Haldol that I love, with my Ativan, because they won't breathe. When you look at a patient's medication list on hospice, they have all of that and more, because what we are doing is trying to make their life comfortable until they can go home. I have a question about what would I recommend in place of Nuplazid. Sometimes, in order to get to Nuplazid for the insurance companies, because it's new and expensive, you had to have failed Seroquel, and you should have failed Clozaril or have a very good reason for not taking it. So if at that point it might be holding down the fort, but it's not living up to the expectations that we have been told it was going to do for us. Another question is, rivastigmine patch, does it have the similar stopping issue as Aricept? And to me, my experience, the answer is yes. So that way, if somebody is taking it and they're tolerating it and they're not having any trouble with it, we ask people, please keep taking it. Let's not make more problems. The second part of the question is, what is the range of the window of use? And if you can clarify that for me, I just want to make sure I answer your question right. Another question is, how do I feel about ketamine for pain control? That is a loaded question, because ketamine is very dopaminergic. It can cause hallucinations. And in the Parkinson's brain, we know that dopamine is very fragile. There are 4 dopamine pathways in the brain, and they're all in various states of functioning in Parkinson's. 2 of the 4 are great, 3 of the 4 are not. It's always a combination of good and bad, and we never know which one is which until we add something like that and things blow up. I personally don't like ketamine because of the propensity to cause psychosis. We have had people come out of anesthesia with ketamine swinging. They are seeing all kinds of monsters in the room. Somebody's trying to kill them, and they have superhuman strength, and they usually fall off their gurney. a doctor gets hurt, a nurse gets punched. I personally myself don't like it. And there's a whole bunch of other medications that we can use to control pain and to use for anesthesia, but that's for the anesthesia folks to talk about. Let's see, do I have all the, I think I'm caught up on questions. If you have any more questions, let me know. Oh, so I wanted to make sure that there's a risk of falls because people get woozy with these medications. Breathing trouble is usually at high doses, or if you have compromised breathing already, like emphysema or COPD. It's not enough to kill, it's enough to impair. Worsening, worsening memory is the one I just talked about. I have patients tell me that they've had Xanax for 30 years and they took it the other day and it made them their memory fuzzy. First off, it's 30 years old, so please throw that out 25 years ago. But second, no, it does. It creates kind of a cloud. So those are the medication options and the fors and against, the pros and the cons. One of the best things for any of these symptoms and their level of distress for the patients and their loved ones is therapy with a therapist. And I have to say, I really appreciate that. And I was not paid to say this, but I appreciate that the Michigan Parkinson's Foundation has therapists trained specifically in Parkinson's, because then you don't have to explain yourself. You can say, my off on, my cinnamon. You don't have to explain it like you would to another therapist. Some people don't want to go to therapy. They think it's a weakness, or people are going to judge them. First off, you don't have to tell anybody that you're going. Second of all, if you just had surgery, you're probably going to go to physical therapy, because physical therapy will maintain the strides that you made in the physical surgery. So that's the same thing with psychotherapy. The medications will do quite a bit, but when you have therapy in the picture, they do more. It's like the therapy does more and the medications do more. I call them strategy planning sessions because that's what you're doing. You have an issue and you're going to plan how to work on a strategy to make this more comfortable, to make it go away. Something is not the way you want it to be. So how are we going to make it work? It's also too, it's nice to have somebody who's not in your head all day talking to you, because when you talk to yourself, you tend to go over the same script or the same rhetoric. When you have somebody on the outside, it's helpful because they get a different picture. Coping skills. Some people, so like my coping skill, I would say, is exercise. So like I said, I can't meditate to save my life. I can't pay attention on that. But there are other coping skills like journaling. People like to write in journals, whether it's the bad stuff that happened today or the things that they are grateful for, or we'll give them homework. We'll say, okay, if when you have these negative thoughts, this is how we can change them into good thoughts. Or I keep seeing in my journal that I'm talking about this one event that happened 20 years ago. I'm going to bring that up to my therapist, and why am I bringing this up after 20 years? They'll figure that out. They'll work with you on it. They'll teach you different coping skills. Mindfulness and meditation are, like I said, the two I can't do, but some people really like that. They like the imagination of it. They like to be able to sit and clear their thoughts. It's really great when you pair it with yoga, because you get the physical and the mental exercise there. Some people are doers. Some people like activities. That's why I say housework. But especially now, because nobody's going anywhere until COVID-19 settles down. But any kind of activities. What was great before COVID is we had like the Brown Center, we had support groups. You could go meet your friends at the mall and go for a walk and then have coffee after that. That was phenomenal. Anything that involved socialization was phenomenal. If you do decide to do true official therapy, the one that would be the most beneficial in the situation of Parkinson's is called interpersonal therapy. There's also cognitive behavioral therapy, there's acceptance and commitment therapy, and they all have their different structures and theories within them. But interpersonal therapy is fantastic for Parkinson's because it focuses on transitions. So you've transitioned from perfectly well and everything is going your way to fighting against a body that's not doing what you're telling it to do. You're transitioning from somebody who may have never even taken an aspirin for a headache to taking 2 or 3 different medications for Parkinson's just to get up and get moving. You may be focusing on the transition from work to retirement, whether you have Parkinson's or not. Sometimes there's a focus on being married to not being married anymore, whether that's from being a widow or a divorce, or just separation. There's also the transition of your kids growing up, so they're not in the house anymore. Now what do you do with yourself? That's a transition. Any kind of transition like that, the interpersonal therapy is fantastic. And you don't have to go forever, seriously. I have patients that have been in therapy for 30 years. They're not getting anything out of it. I have some that go for 12 sessions, once every couple of weeks, and they get more bang for their buck because there's structure to it. There's a focus to it. One of the questions has come up, would I be able to recommend something for pain for a neuropathic type of pain with Parkinson's? This is actually interesting. One of the medications I did not mention was, it's a cousin to Effexor venlafaxine, which is Cymbalta duloxetine, and it will work for depression and anxiety in the context of Parkinson's, and it also helps with neuropathic pain. Another is the nortriptyline, amitriptyline, the old tricyclic medications. I give them to my patients for depression and anxiety, migraines, IBS, and neuropathic pain. So one of my ladies has all of those, and I started her on, oh shoot, what was it? Oh, crud, I can't remember what it was. It was a cousin of it. It wasn't nortriptyline, but it's one of its cousins. And she called me in a couple of weeks and she said, this is taking care of my IBS and my feet feel so much better and I don't have as many headaches. What did you give me? This is like magic? And I said, it's not magic, it's science. It's the beauty of science is you told me you had all these things and I found one medication that happened to take care of all of them. And again, the dose of that is low. It would be considered a homeopathic dose by anybody else, but it's low that it doesn't mess with her and give her side effects, and it can help with those other issues that she had. Another one is gabapentin, which is Neurontin. A lot of my people with Parkinson's do take that with all the rest of their medications. Cymbalta, duloxetine, and the tricyclics we usually do not use together because of serotonin syndrome. Sometimes, and this is strange, usually it's high doses of two different medications that act on serotonin receptors in your brain can cause serotonin syndrome, and it can be life-threatening. So we usually don't. I do, though, have some patients that take the maximum dose of Cymbalta with a tiny dose of a tricyclic, and then I have patients that take higher doses of the tricyclic with lower doses of the Cymbalta duloxetine. So there's different combinations in there that we can work with. The one side effect of gabapentin Neurontin can actually be confusion. So, excuse me, if somebody already has a level of confusion, we want to make sure it's not getting worse. If somebody comes to me with brand new confusion and they've never had it before, I'm looking at their medication list and when they stopped and started certain medications. And if they just started the Neurontin gabapentin, that's my culprit. But sometimes, and I have a very lovely patient that says he would rather sacrifice some of his memory for his depression. And we work with that. We want to make sure his memory doesn't get too bad, that we're running into more trouble. But we want to make sure that his depression is well taken care of too. So you will find that patients can barter, or they'll barter with their doctors to say, okay, well, I'm feeling fantastic with this, but I'm having the side effect. I had a woman once who lost diarrhea. She lost 20 pounds from diarrhea from Zoloft, sertraline, but she felt great. And I said, honey, we cannot do this. You cannot lose all this weight from diarrhea. It can mess up your electrolytes. It'll mess up your heart rhythm. We can't do this. But she felt great. So I said, well, let's switch it. I said, you're getting good benefits. Let's switch it to a similar medication. And we did. And the diarrhea cleared up and she still felt well. So that's why we ask you all these questions. Please don't ever be afraid to tell your doctor you're having a side effect, because there's 99% of the time a different path we can take that helps you feel better without giving you all these problems. One of the other questions that has come up is Tylenol okay for leg pain causing waking up at night? That's a yes and no. It depends on what's causing the leg pain. If it's arthritis or old injuries, it's usually okay. If it's the muscle cramps that people get with Parkinson's, I don't know. Does it work? That's the question. Is it working? If the medication is working, then okay. We just want to make sure we don't take too much Tylenol because we don't want to hurt the liver. But you always check with your primary care doctors and other specialists too, because they can help you with that. As long as it doesn't hurt, it's not hurting your liver, it should not be a problem. But if it is, just go for it. Just make sure your primary care doctor knows that so they can keep an eye on things. So my last slide here is a bunch of resources. What I did not talk about is suicide. And I'm kicking myself now because that's a huge, huge issue in Parkinson's. The suicide rate for Parkinson's is extremely high within the first year of diagnosis. It's higher than almost everything else I treat. If anybody is ever having any thoughts of suicide, there's 2 phone numbers. It's the suicide hotline, which is a 3-digit 988, which is like 911. And then there's the National Suicide Prevention Hotline. There's also your doctor. The most visited specialist the week before somebody commits suicide is a primary care doctor. It's not me. People don't come and tell me that they're having these thoughts. People can get a referral and they're waiting and waiting. And the waiting, I say it's about a week, say it takes a week to get in. That's a long week when you're not feeling well. We always say, call the primary care doctor, call these other people. It's something we can do. You guys probably know Robin Williams and committed suicide when he got the diagnosis of Lewy body dementia. That's exactly what happens with our patients. So that's why suicide is not at all a joke. It's a big issue and we can help, we can take care of it. It doesn't have to be that way. You guys know you've got the Michigan Parkinson's Foundation. There's the American Association for Geriatric Psychiatry, which is me, and only 3,000 of my best friends. There are only 3,000 geriatric psychiatrists in the entire country. So that means there's one of me for 6,000 of you. So if you know anybody that wants to go into medicine, who wants to do psychiatry, the best field, the most rewarding field, the one where you have the most fun, is geriatric psychiatry. Where else can you play bingo with your patients? Where else do you do a video visit and it's full of family? You've got the 2 kids and their 2 kids and their 2 kids, and there's a dog that barks and comes in on the video. It's the best thing, like the entire family. There's the National Alliance for Mental Illness. That's more for the families because the families need support, the families have questions. And of course, I have to advertise for Henry Ford. If you're looking for a Henry Ford doctor, here's some phone numbers. If you're a military veteran, you have a special place in my heart. And the VA does a really, really good job of taking care of its veterans now. A lot of Vietnam veterans will not go back. And I understand why. It was a shame the way they were treated when they got home. And I would have to say the VA has made up for that in strides. So this page here, the va.gov geriatrics page, this is specific to Alzheimer's and dementia. But if you just go to va.gov and you search for whichever condition you're looking for, you will get a very thorough page with links, with education. It's phenomenal what they've done. They even have a caregiver program. So if your spouse is a military veteran and they become incapacitated, then you, the spouse, usually the wife, not being sexist, but 85% of our military veterans are men. So usually the wife becomes a paid caregiver. So they get paid to do the job they already signed up to do. For better, for worse, in sickness and health, they get paid to be that caregiver. So if you are a military veteran, check it out. It's phenomenal now. The Alzheimer's Association is the last resource on this page, and this is a trick. They're called the Alzheimer's Association, the first 2 words, but the rest of it is that they take care of patients with other dementias too. Lewy body, Parkinson's, all kinds of stuff. They have wonderful resources. And the resources and strategies that I gave you in the slides earlier that talk about like the reassurance or the redirection, the non-medication strategies, those all come from their website. So I totally stole it from their website, but that's what we advise patients anyway. But their website is very good. We have, in the Henry Ford system, we have 2 of their social workers embedded in our neurology clinic just for us. They're not supposed to, but we do let them go to other departments and help out. But they're phenomenal. So we have them just for us. And if there's anything that ever came up, we call them and they are on the case. So with that, do you have any more questions?
You know what? Thank you, Dr. Boore. This was outstanding. I can't thank you enough. I think that we have gone way over the time that I feel like we've taken a lot of your time. So I am so grateful to everybody on this call. We did record it. And I think it would be really great if you could send me your PowerPoint, if you don't mind, if I could share that, that would be awesome. So I think we will, unless there was another, I don't see any, let's see.
Yeah, no, this was great. Thank you for having me. I really appreciate it.
I think we're good with the questions. You've been so generous with your time. So I want to say good evening. Thank you again. And good evening, everybody. And if you need to get in touch with Dr. Boore, call me or email me, and I can give you the information on how to make an appointment with her. As she said, there's very few geriatric psychiatrists around. And so when we found her, we jumped all over. We were so excited. And I applaud Henry Ford Health System for adding her to their system. And so give us a call tomorrow or email us and we'll get that information out to you all. Okay, folks, I'm going to say good night. And again, thank you. Bye.
Thank you.
Bye. Take care. You probably have to put a 3-year-old to bed.